this clubfoot can come even as a short note in the exam. So you must know. So these are all syndromic clubfoot. Another important thing is to know is something called as a complex or atypical clubfoot. So this is a deformity with all the four components, but what is important is that they have a very rigid equinus. You see almost it is at 180 degrees. The axis of the tibia and the foot appears to be almost in straight line because of very severe equinus. There is a deep cleft in the plantar aspect which is running all through from medial to lateral, as against in clubfoot where you just have a medial deep crease, and you have severe plantar flexion of all the metatarsals. You have a short hyperextended toe, and the Achilles tendon is so tight that the tight Achilles tendon is felt right up to the mid level of the calf. So this is a typical, it's a special variety of clubfoot which is called as the atypical or complex clubfoot. If you see such a foot, then you can say that because the treatment is also different than the classical Ponseti. Here we use something called as a modified Ponseti technique. So you should read about it. Here we will not go into the detail, but it is important. So if you have read it, if you get that case and if you say it's a complex clubfoot, then you get extra marks. So you are above the others. So identify this typical variety which is very severe, very tight with a deep plantar cleft with a short stubby foot and a hyperextended great toe. It's a complex or atypical clubfoot. Also, you must classify according to the treatment stage what type of clubfoot it is. So we talked in the beginning whether it's idiopathic or secondary. Also, you must know whether it's an untreated clubfoot, whether it's a treated, resistant, recurrent, neglected. Some people now say you don't use the term neglected, not just for this but for anything. You have neglected Monteja, neglected Latin, like some people say you should now replace that neglected term with late presenting because it shows neglect on some part. So maybe you can say late presenting. So untreated is any child who is less than 2 years, has not received any treatment. So it's a first time presentation. Untreated, treated, obviously you have treated and with Ponseti technique and it's corrected, it's treated. Resistant is if your child with a previously untreated clubfoot, but when you give Ponseti casting, it does not respond as it should. That means there's something resistant features in that, which most of the time is something like as an arthrogryposis or any syndromic child. Sometimes they do not respond to severe casting, and that is why we say it's a resistant clubfoot. So this you can see only if the child is already under treatment and has presented to you. So if you ask the parents or something whether the child had more deformity, but still after casting it is not responding, then it's a resistant. Recurrent or relaxed clubfoot is the one which was already treated, was corrected, but now again started having deformities, like again equinus has started or varus has started, then you can call it a recurrent clubfoot. And neglected or late presenting is a child who has presented for the first time beyond 2 years, then you called it as a late presenting, which happens in our country many times. So these are all the other terminologies which you must say in your diagnosis. Another important thing is the neurovascular examination. You may think that this is just a clubfoot. I mean, all the other cases you always say no distal neurovascular deficit. Here also it is important because clubfoot deformity can also have associated neurological problems or vascular problems. So it's something called as a drop toe sign. Means the child, when they present first time, you can tickle the plantar surface and see whether the child is able to extend the great toe. If he is not, then that means the common peroneal nerve is also involved in addition to clubfoot. And this is very important to document at your first go, and also to examine when you present. You must say that the child has no, active toe movements are present and there is no drop toe. What is the importance? Why should we document this? Anybody?
Polio?
No, we are not talking about polio. We are talking about clubfoot. What if you miss this? What can happen?
Physically disabled.
Yes?
Physically disabled.
Physical disability means, so one thing is that the child could be a neurogenic, which you are treating like an idiopathic, and once the child is corrected, the child may not be able to walk or still later develop. So this, what you have missed, could be a problem. Secondly, what do you do? How do you treat them? You give serial casting if you have seen or treated. So the treatment for clubfoot is serial casting, and you give an above knee cast. Suppose the cast is tight, sometimes because of the cast and compartment and all, you can have secondary common peroneal nerve palsy. So if you have not documented, later on once the child becomes little bigger and the parents notice that the child is not now moving, they can attribute it to your plaster treatment and you will be liable for the problem and you could have medical legal problems. So always first visit or whenever the child presents or comes to you in your exam, you always check this, and the child, if small child may not be able to test like you tell them to extend the toe, but what you have to do, tickle the plantar surface, that will spontaneously give you the extension of the great toe, and then you document that there is no associated nerve pulses. So there is importance of neurological examination. So this was an article where they seen that, and secondly, if they are very difficult to correct, and even after you correct, because there is no power, it again goes into equinus. So they can have long-term bracing may be required, relapse rate is high, they may need surgeries early, and sometimes you need to do a early tenotomy. So you must document whether the common peroneal nerve is normal or no. Secondly, also as I said, the vascular assessment is also very important, because there are some papers which have shown that almost 40% of the clubfoot may have deficient flow in the dorsalis pedia. So when you see the child, palpate your dorsalis pedia, PTA, PT, all those pulses, and compare. If it's a unilateral, you can compare with the opposite side about the volume. So there may be some vascular insufficiency which may have relevance in your treatment. So neurovascular examination again is important. Though it is clubfoot, you may think that what we are talking about neurovascular, but you must say also in the exam. And when the examiner asks, you can give these reasons. So there is this Ortho sign, and you have the vascular anomalies which are documented to be associated with clubfoot. So now knowing this, coming to the examination, so history and all again, what history do you ask when you come have clubfoot cases? So one, the deformity present since birth, okay, then
Delivery.
why delivery history is important?
Breech position or
Breech is not much for clubfoot.
Oligohydramnios.
So
Oligohydramnios.
as sir had told earlier, any history, here you don't have onset duration, there is no complication, no pain, it's a deformity. The only thing is deformity origin is from birth or no, that you must ask. Okay? If the child is present later, whether the deformity is progressive, then you can think of secondary causes like a neurological problem, muscle imbalance, then developing deformity. But the other history important is to know the history suggestive of etiology, which sir said you must ask. So all the known causes you must know. So no one knows what the definite cause is, but it is a combination of genetic and environmental problems. So ask about the perinatal history, so any oligohydramnios, twin pregnancy, family history, all these other things, or the mother could not feel the movements of the child, which could suggest arthrogryposis, so decreased movement. So all the history suggestive of the etiology you can ask, and if the patient has already undergone some treatment, cast or brace or something, you must start about the details about the treatment history. What was the plaster given, whether any tenotomy was done or no, how long was the brace given, so all those history. So history is going to be very small component, but again important if the child is presenting late. If you get a very small newborn child or 1-2 months, then the history suggestive of etiology. Coming to examination, the local examination, you must, in addition to the deformity, pay attention to these components, because many times they get missed. So the foot size, if it's a unilateral, then the foot size is always going to be smaller compared to the opposite side. The calf circumference also will be lesser compared to the opposite side. The foot length, the limb length, everything also may be little lesser compared to opposite side. And if it's a walking child, you may get this big velocity. If the child keeps on walking on a deformed foot, then on the anterolateral aspect you may have a velocity. So this I am putting first because these things get neglected. You just focus on the deformity, then the size, length, girth, all these measurements get neglected, but they are also important. So at the end, you must examine in a unilateral, bilateral it will be both. If there is one side severe than the other, you may have some discrepancy, but otherwise in unilateral it's very important to look at all these: the foot size, the thigh, the limb girth, the length, and of course before you jump on to the details of local examination, the general examination is very important. So as we said, spine is very important. You must look at the stigmata of underlying neurological problems. So one is the big swelling, meningomyelocele. Any other? Sir showed in his presentation. Tuft of hair. Yeah, so you have tuft of hair. You will not see outside, but you may have a tuft of hair or you may have swelling. All these things can suggest that there could be underlying neurological cause. And hip examination, because many of them are associated with other hip conditions like DDX, CDK. Other joint examination is important because this could be a part of generalized problem like arthrogryposis. and many syndromes which I talked about. So this is a Freeman-Sheldon syndrome, like a whistling face. This is a Mobius syndrome, like a mask-like faces because of the facial palsy. So you must examine the child as a whole. So these examinations are important, and then you move to the local examination. So in local examination, like any other orthopedic case, you have inspection, palpation, movement, measurement. But here what we are interested in knowing the components of the deformity. So in inspection, you just can describe that it's a bean-shaped foot, small foot with a convex lateral border and a concave medial border. But then you have to do the scoring, which is very important. So various scoring systems were described earlier, but what is most commonly used is this Pirani score, which was designed by Dr. Shabik Pirani from Canada. And everyone should know this because the whole examination and the examiner will ask you to demonstrate and show what the Pirani score is. So anyone aware of this or has done this? No one? Okay. So let me explain, because this is the main important crux of the clubfoot examination. So you have two components. You have a hindfoot contracture score, which has 3 points. You have 0, 0.5 and 1. And you have a midfoot contracture score, again 0, 0.5 and 1. Okay? So 0 is that there is no deformity, 0.5 is moderate, and 1 is severe. So if the score is 6, then it's a very severe deformity. If it's 0, that means normal. Somewhere 1, 2 means mild deformity. So here again you have to look, feel and move. So there are 3 components of each contracture score, and in each component you have one aspect which you look at, one which you feel, and the third is where you move and decide. Okay, so let's go through this in detail. So in hindfoot contracture score you have something called as a posterior crease. So this is a child who has a equino-cavovarus deformity. So everyone convinced that this is a clubfoot. It is not metatarsus varus, it is not postural. And the general examination we have done, everything is normal. So now we look at what is the posterior crease. You can see this deep crease there because of the equinus. So normally if you look at all your feet, you have multiple fine creases at the back of your ankle. So if there are just multiple fine creases, then it's normal. So that is 0. If there is a deep crease, but you can see the depth of the crease. So it is not very deep, but still you have, compared to this multiple fine creases, you have a crease, but still you can make out what is the depth. So it is mild, deep cleft, that is 0.5. And you have a very deep cleft like this. Now I cannot make out where is the base. It's so much in equinus that the cleft is very deep, and it is 1, very severe. So posterior crease, you look at the foot from behind, see whether there are multiple fine creases, deep, mild cleft or a deep cleft. That makes it 0, 0.5 and 1. So that is one component of posterior crease. Then so this you are just looking at the foot. You are not doing anything. Then you feel the heel, and this is called as an empty heel sign. So what do? You hold the foot and you put your thumb or index finger at the heel from plantar aspect and see how the feel is. So now everyone, if you see the pulp of your hand, it is soft. Okay? So that means you are not able to feel the underlying calcaneum. It is so much in equinus that you are not able to feel the calcaneum bony prominence. So it is looking, the feel is just very soft like the pulp of your hand. That means it is 1. If you are feeling firm, means you are able to feel but not like bony hard, like the nasal cartilage or the ear cartilage. Not very hard but firm. It is 0.5. And if you are able to feel it like a hard calcaneum, that means it's not too much in equinus. You are able to feel the calcaneum like the temple, like the forehead, like a bony hard feel, then it is 0. Okay? So understood, very bony hard feeling. So that means the foot is not in equinus. It is very mild. It's almost correctable. You are able to feel your calcaneum. It is 0. Firm 0.5 and soft feel is 1. So that is your empty heel sign. So this you are feeling. So one component was look, posterior crease, feel, empty heel, and now move. So now you hold the ankle, foot, try and do dorsiflexion and see how much you are able to correct by your gentle pressure. So if you are able to correct, get it into dorsiflexion, so almost about 20 degrees dorsiflexion is our end point. So that means foot is completely correctable. This may happen not in the beginning, maybe at the end of UCAS. That means it is 0 now. So rigidity of equinus, this is the third component, so this is 0. If you are able to correct it till neutral but not going beyond that, then it is 0.5. And if it is completely in equinus, that means 1. So this when you are moving and deciding the score. So what are the 3 components of hindfoot contracture score? You look at the posterior crease, you feel the empty heel, and you move and check the rigidity of equinus. And that way you score each component as 0.51. So that makes it the total score of 3. That means it is very severe. If it's 0, that means that component is corrected. So this is a hindfoot contracture score. Similarly, we have 3 components of the midfoot contracture score. So again, here in the midfoot, one component is look. So just as you were feeling and you were looking at the posterior crease, now you look at the medial crease. So again, this you are convinced it's a congenital pterygus equinovarus. You look at these medial creases. So if there are again multiple fine creases, that is 0. You have few, little deeper creases, it's 0.5, and you have a very deep cleft again where you cannot see the depth of the cleft, very severe side, that means it is 1. Okay, so similar bases as we had for posterior crease. Then you feel the lateral curved border. So now we are looking at the foot from the sole. You have a pencil or a ruler. You put across the lateral border of the foot and see where you have the curvature. So normally if the whole lateral border, the ruler or the pencil is touching the whole lateral border, that means there is no curving, no forefoot adduction. So that is 0. If it is curving beyond the midfoot, so at the level of the metatarsal, midfoot level, then it is 0.5, and it is very severe and curving just at the hindfoot, that means it is 1. Okay? So this is the curved lateral border. So here you are feeling. So that is the feel component. And this is the move component, that is the lateral head of talus. So what do? You palpate the head of talus. So the important thing, where do you palpate? Just in front of the lateral malleolus. You palpate the lateral malleolus just a finger breadth. Just in front you will feel a bony prominence. Because your foot is curved, you feel the lateral head of talus very prominent. And then you hold the foot and try and correct. So the whole club foot is actually you have one talus and you have the entire calcaneopedal block which is turned around that, and that leads to the deformity. So when you are correcting it by supinating and abducting, you are actually trying to correct the calcaneopedal block around the talus. So if it gets completely reduced, means the head of talus gets deepened and you are not able to feel by after correcting, that is 0. If it gets partially corrected, it is 0.5, and if it doesn't correct, it is 1. So that is the lateral head of talus which you will see after moving the foot. So you have again 3 midfoot contracture score. Look at the medial crease, feel the lateral curved border, and move and see the reducibility of the lateral head of talus. So that makes it 3. So hindfoot contracture score 3, midfoot contracture score 3, and total is 6. And this is very important at every subsequent visit. So you will get in an exam where you will have to say the pyramid score is this much. So that will tell us, and obviously when you see the examiner will ask you how will you check. So each test component you must know how to do it. So if you have a case, sometime you can practice. These figures are available online on all the anything, but this is very important how you check and how you reduce it. There is another score. This is just for theoretical purpose. We all use pyramid score, but if you have already done it, in your theory exam, if you are asked, then there is one thing called the Emmanuel score, where there are some other components. It's a 20-point score. And they are divided into whether it's correctable from 90 to 45, 45 to 20, 20 to 0 or more than that. And then, so you can read up about this, but it is not mandatory that you know all how to do it, but as a for theory you may be required to know the Emmanuel score. So these are different components again, how you measure 1, 2, 3, 4, and then the other, in that they have some other parameters to make the total score of 20. So if it is score is less than 5, then it's a benign deformity. If it's 5 to 10, it's moderate. 10 to 15 severe, and more than 15 it's very severe deformity. Sometimes you get walking children. In our country, children have not, or they have done some local rural treatment, massage and all, and then they come with a walking age. So many times in walking age, all the creases, everything is gone. You no longer have those classical scores which you have in pyramid. So there is a new score which is described for walking children, which is called as a Pirani-Bohm-Sinclair (PBS) score. Again, this you all want to you can read up, So they have divided some points in standing, some point in walking, some points on sitting, and then they have described many other features and described the PDA score. So this, if you know and you say in the exam, I mean if you want to score very high or something, but otherwise for theory, if you know at least that there is a score like this and you have various other components. So ultimately when you are saying the diagnosis of clubfoot, you have to say the age of the child, of course that will be evident. Whether it's a unilateral or a bilateral, whether it's an idiopathic or a secondary clubfoot, what is the Pirani score, and also then measure that the foot size, especially in unilateral case, how much it is shorter, how much is the limb girth difference, how much is the limb length discrepancy, whether the neurovascular examination is normal or no. So you have examined the drop toe and you have palpated the pulse. And always look at the general examination, hip, spine and all the other joints, faces, everything. And why has the child presented just for the deformity or in a walking child with unstable gait or whatever. So when you are saying the diagnosis, all these components if you say, so if I have a case like this, I said, this is a 3-month-old child with right-sided, idiopathic, untreated congenital talipes equinovarus with Pirani score of 5, with foot size 1 centimeter shorter than the other side and limb length discrepancy and girth discrepancy of 1 centimeter with normal neurovascular examination with no other general features of any abnormality, presenting now with mainly the deformity. That completes the diagnosis. If you say this in one word, you already passed. Rest is just like whatever the questions they ask you to demonstrate. Of course, the questionnaire and all this will go on to treatment. If you reach this directly, then the examination will go on how to treat, what is the bracing protocol, all these. I did not here today, the focus is more on the examination, but all this you should know. These are scoring cases. So anyone has any question on just the examination part, we can take that. Anyone has any doubt on that? So next time, whenever you have any case or any other hospital, if you have, you are not getting many clubfoot cases, try and get one case and then everyone should practice scoring checking the Pirani score. Any doubt? Any questions? No questions? It's either everyone is sleeping post lunch or I have made it very clear. One of the two. Okay, so then we move on. At least Jenu, Varam, have you seen cases? No? There is no pediatric orthopedic. Sir, you must invite me to with the cases to teach them. Because at least in DNB and everywhere these cases are very, very common. Patients presenting with both legs, knock knees. No one has seen these cases? No? Very surprising. You have? So our country, a lot of patients have this rickets. So again here there are certain specific points and you may see patients like bilateral problems, unilateral problems, very small children, bigger children, somebody with something called, what is this called? What is this child has? So this is Jenu valgum. At least you know that is knock knee in layman terminology. What we call is a Jenu valgum. This is Jenu valgum. This is Jenu varam. This is Jenu varam, tibia varam maybe. What is this? Vein stem deformity. So what is that? One side varam, one side valgum. Okay, so you may see again various spectrum. You may see at very young age, adolescent age. Some of them may be physiological, but some are pathological. Okay, so pathological could be having any of these causes like rickets, post-rickettage, Brown's disease, dysplasia, or if they come as unilateral, then it could be secondary to growth arrest, facial arrest because of trauma or infection. So in your exam, you must find out whether it's physiological, whether it is something pathological, and then the cause. So for that, you must know what is the normal development of knee in all of us. So all children are born with varus. They have about 10 to 15 degrees of varus. Then they start standing, walking, then there is increased varus. Then by 1.5 to 2 years, they become neutral. Then they go into excessive valgus. And by 4 to 7 years is the time where the normal valgus is established. So when you see a child in any of these curve patterns, so suppose a child presents a newborn child, many of the newborn children parents are worried, so my child has both heads and they present to us, but many of them are just physiological because the normal mental is still not developed. So you must know what is, if they are presenting in that particular age and they are responding, their deformity is not progressing, that they may be very well in the normal range. Now what are the symptoms? What is the history in these patients? The parents always come for the appearance. They say it is looking bored, it is looking knock-knee. But look at the child, the way the child is walking with so much severe valgus deformity. He is almost walking like a circumduction gait. Both knees are touching against each other with a lot of gait disturbance. So they have also functional problems. The virus can have waddling gait, and because of which they can have frequent falls, difficulty in running, cannot take part in sports, they have very slow speed. Sometimes they get anterior knee pain, discomfort. So when you are asking the history, all these they will not tell. You have to say whether they have frequent falls, whether they are able to actively participate in sports, do they complain of knee pain. Because as I said, the parents or the child, if it is bigger, or you get a history from parents, they will say it's just a deformity. But you ask proactively all these symptoms and then ask what are the problems. Secondly, as we always say, you must have the history of etiology. So whether in our country, as I said, most of the common cases are nutritional rickets, secondarily leading to deformity. But sometimes they can have familial problems like hypophosphatemic rickets or some skeletal dysplasia. All the parents, everybody in the family has problem. You ask about their diet history because that may be having deficiency in calcium. Ask about milk allergy. Or if it's a unilateral case, always ask whether there was any trauma, because that or infection which can lead to growth arrest and can lead to deformity, which will not be bilateral. So difference in etiology in a unilateral case versus bilateral. Always if you see unilateral, always ask about trauma history or infection history. Again, as I said in clubfoot, here also the general examination is important because this deformity could be just part of the whole thing of the child. He may have skeletal dysplasia. So here the height and weight are also important. You must check the height of the patient because short stature is again associated with a lot of skeletal dysplasia, hypophosphatemic rickets, achondroplasia. All these people are short stature. So you must take the height of the patient. You must also ask about the weight. If the child is obese, Blount's disease is very common. What is Blount's disease? Anyone?
Tibia valgus.
It's MBBS question. MBBS also you
Tibia
must know what is
vera.
Blount's disease. Tibia vera. So infantile Blount's disease, where the problem is in the proximal tibial metaphysis, medial. That is sloped or arrested and that leads to varus deformity. So these people are obese children, early walker, they have this Blount's disease. So always take the height and weight and have the child examination as a whole. General examination is important. They could have these features of rickets. Again, this is all MBBS. You have double mandibular, you have widening of the ribs, you may have rickety rosary, healing of the ribs, all these things. So general features, bossing, these things need to be checked. Also, what is this score which is demonstrated here? Beaton score. Everyone should know about Beaton score. Examine in a child, especially a child has general ligament laxity. Then when they stand, the deformity gets exaggerated. They will have significant genu valgum. So when you examine them in the lying position and you see on standing position, the distance and the deformity will be different because of the generalized ligament laxity. So always do the Beaton score examination. And again see whether the child has multiple swelling. So sometimes some conditions like multiple osteochondroma, multiple enchondromas can have skeletal dysplasia and multiple deformities. So, and also you must rule out skeletal dysplasias like metaphyseal dysplasia, hypochondroplasia. So after all this general examination, then we come to the local examination. So in genu valgum varum, some things what you have to know is first whether it's unilateral, bilateral. Secondly, you have to assess, quantify the deformity. How much is the deformity? Whether it is symmetrical, asymmetrical. So here the one child, this child has unilateral genu valgum as against the other child who has bilateral. So the cause may be different. You have to look at different history and everything. So how do you quantify the deformity? Two ways. One is by measurement. So in genu varum, you take the intercondylar distance. In genu valgum, you take the intermalleolar distance. And you must have to measure the angle. So that is a tibiofemoral angle. So use a goniometer, one limb across the axis of the thigh, center at the knee joint, and the other limb across the line of the tibia, and then whatever angle you measure is your tibiofemoral angle. So when you are quantifying, you say the intermalleus. Suppose the genuvalgum intermalleolar distance is 12 centimeter and the tibiofemoral angle is say 12 degrees. So that way you have to quantify the deformity. Next, the examiner will ask you is where is the deformity. So genuvalgum is a knee, not knee. So the deformity whether it's in femur or whether it's in tibia. So anyone knows about what is this knee flexion test? It's evident. What is shown here? No, Ellis test is different. That is for your rectus tightness. So here the child she's lying down. The child has genuvalgum. Everyone agrees? Okay. Second picture, what is done? The knee is being flexed. Now you look at the angle. Whether you look at you see is there a knee genuvalgum now? The deformity is disappeared. So on knee flexion, the deformity is disappearing. What does that indicate? Where is the deformity? Femur. Why? Why does the deformity disappear on flexion? So when you are flexing, the posterior part of the femoral condyle is now articulating, which is non-weight bearing, which is not affected. So the deformity is masked. So if the deformity would have persisted, that means the deformity lies in tibia. That will not disappear. But if the deformity is disappear on knee flexion, that the deformity is in femur. If it is partially disappearing, that means both are affected, partly in the femur, partly in the tibia. So this is very, very important clinical test. You will be definitely asked about where is the deformity. You have to do this knee flexion test and know where the deformity is. Another important test is a cover-up test, which is important. Is a screening test to assess the alignment in very small children between 1 and 3 years. Many of them present with bow legs. We studied in the first slide that is the normal development of knee angle. All the children are born with bow legs. So whether it is a physiological bowing or is it because of infantile tibia one, that you decide by doing this cover-up test. So what you do, you cover, now this child had a bowing. So you cover the distal part of the leg and check whether the proximal part of the tibia is in valgus or is it in varus. So when I am covering up the femur and the tibia, this part still looks in valgus. So that means the deformity, it is not tibia vara. If it was tibia vara, then the proximal part also will be in varus. Now this child who has a varus deformity, when I am covering the leg, the alignment of thigh and tibia is still in valgus. But because of the gentle bow, the leg is appearing in varus. So everyone understood if on covering up, the proximal part is still in valgus, it is physiological bowing. In covering up, if the proximal part was in varus, it was an infantile tibia vara. And this is very important. So this is a cover-up test. So if you get a child between 1 to 3 years with genuvarum, they will ask what is the cover-up test and what is the diagnosis. Now there are certain traps in the examination. So you must always know that when there is a deformity, it is not always one plane or angular, it is always a combination of angular and rotational. So if you have external tibial torsion and an internal tibial torsion, it will appear like a genuvarum. Versus if you have internal femoral torsion and external tibial torsion, it will appear like a genuvalgum. So always, even if you have a valgus varus case, always do the rotational test, like this child, like almost like what we call as a O deformity, so much of varus, looking like an O. When you flex the knee, what you are seeing, the varus is not only disappearing, but you see the alignment of the foot with the tibia, it is completely like internally rotated. So here the varus is not too much, but there is also a lot of internal tibial torsion which is appearing like varus. Okay, so that is why you have to check the torsion profile. What is the rotation and how do you check it? How do you know how much is the femoral anteversion, femoral rotation, how much is the tibia rotation? Craig test. Okay, you do Craig test which you will see in hip, and for tibia you see the high foot angle. Okay, that will give you the tibial torsion. So either you do the Craig test or you check your internal and external rotation by making the child grow. If there is excessive internal rotation, it suggests anteversion. If there is excessive external rotation, retroversion, and this is the thigh foot angle, whether it is in internal tibial torsion or external tibial torsion. So whenever you have genuvarum valgum case, always do the torsion assessment also. And last but not the least, also check for instability, because if you have a long-standing genu valgum, the child can have patella dislocation. And like this child, every time patellofemoral maltracting, and when you flex, the patella is subluxating. Also, when you have varus, you can check for the lateral collateral ligament laxity. So after you have done all the quantification, the site of the deformity, the torsion profile, check your instability also. And last but not the least, don't forget to mention the gait. So this is a severe genu varum in an adolescent girl, and she walks with a typical lateral thrust. Okay, so this is a typical feature of tibia vara. You have an adolescent tibia vara. How we consider about infantile, you also have an adolescent tibia vara. So always mention about the gait at the end. So that will complete your examination. And of course then they will ask what. So you must know about how to order for a scanogram. For the want of time, if you want to, you can click it. There is a special way of how you ask for an X-ray for a genu varum valgum. So you must have this particular, otherwise you will not be able to quantify, because then ultimately you want to measure all the angles, you know. What is the metaphyseal diaphyseal angle, what is the LGFA, MD, LDT, all this you can read up. Also when you are asking for X-ray, you want to see for the features of rifts. And finally, if you are suspecting a growth arrest, then cartilage facial bar can be seen only on MRI. So you must have to ask about specific MRI sequence and ask for facial mapping. So that will complete your clinical examination history and the relevant. Of course, you have to ask for the biomechanical parameter, all the biochemical investigation, calcium profile, PTH, urine calcium, to know the etiology. Okay? So we're not going to indicate further cases. So any question on genu valgum, varum? Again, these are simple cases, but if you don't mention all these points, then examiner will keep asking, and then if you know everything, then your examination is complete and it's a scoring case again. So any questions? No questions? Very good. Thank you.
I think that was a wonderful presentation by Dr. Visavi. Very clear idea about how to examine a patient with genu varum or genu valgum, and of course CTV, and all the features, every small detail has been mentioned. So this is something, if you answer all these things, I don't think any examiner can afford to even think of failing you. So you should, I hope you have noted this presentation down and are going to utilize this. We now move to the next segment, and that is on upper limb cases. So we've got cases here today, and we'll start with upper limb. This is shoulder, this case. Who is there? With no injury. Okay. So no injury है तेरे पास? हाँ तो कर दीजिए.